Welcome
Hello.
to
Good morning.
SNU Hospital. Yeah.
Dr. Kim, will you introduce your team and case?
Okay, thank you. I'm HS Kim from SNU Hospital. My co-operator is Dr. Yangammo Hanjeongyu, our faculty, and I was interpreter. Where is he?
Oh.
Okay, Dr. Kim Gi-seok from Jeju National University Hospital.
Good morning.
Okay, let me introduce our case. Slide on. Okay. This 57-year-old male experienced severe chest pain 10 years ago for 30 minutes. MI happened at that time. The patient visited an outside hospital 2 months ago due to abdominal pain, diagnosed as acute cholecystitis. During pre-op workup, they found LV systolic dysfunction, ejection fraction around 30%, and RCO-CTO. After cholecystectomy, the patient visited me, SNU Hospital, for further CTO intervention. Plus, issue in this case is stable status without angina. Do we have to do CTO intervention? Plus, medication not particular. Target lesion is RCA-CTO. 마우스를 가야지. Plant device is shown here, AR1. First wire, field XTA. I prefer field XTA in antegrade because to shorten the procedure time rather than XDR. It failed, miracle, I'm not sure. Supporting microcatheter if necessary, in this case, Crusade. Plus, EKG, chest X-ray, EKG, T-wave abnormality in infero-apical leads. Plus, but in contrast to EKG, echocardiograph shows the dramatic results. Ejection fraction about 30%, wall motion abnormality, whole apex akinesia, mid-anteroseptal, infrareteral akinesia, basal to mid-inferior akinesia with scar change. With this finding, we don't have to do CTO intervention, but our decision totally reversed by cardiac MRI. Plus, cardiac MRI ejection fraction similar, about 30%. Wall motion abnormality shown here, basal to mid-inferior akinesia, basal inferior septal hypokinesia, apical septal inferior hypokinesia. We can see certain movement. Plus, to summarize the transmurality score in infarct territory, basal segment, about 50% transmurality. Plus, mid portion, 50 to 75% transmurality. Plus, apical, 50, 75% transmurality. Plus, here we can see the evidence of viable myocardium in the infarct territory. Plus, viable myocardium exists there. Basal, about 50%, mid, 50, 25%, apex, 50%. Plus, thus we decide to do CTO intervention. Preparatory coronary angiogram shows here, left coronary artery, not particular lesion except for severe myocardial bridge at mid-LAD. We can see big collaterals from LCA to RCA from diagonal branch through corkscrew epicardial channel, suggesting there is a few chance of good septal collaterals. Thus, we have to complete this case with antegrade approach. Because in epicardial corkscrew collateral channels looks easy, but actually it's not so easy. Plus, RCA angiogram shows it's very short, straightforward CTO segment mid portion. Looks very easy. With various kinds of breaching collaterals. Plus, in a static image, we can see a direct connection, no CTO. But such a direct connection disappeared in another projection angle. Thus, The image of direct connection may be a kind of biased image composed of overlapping bridging collaterals. Thus, we have to be very cautious to negotiate, to navigate short CTO segment. Plus, CT shows no calcification CTO segment. Looks easy. Additionally, there is an unstable plaque, proximal RC. Consider the coverage of stent length. Plus, to summarize our case, despite the absence of symptoms, we decided the revascularization for RC-CTO due to one, relatively young age, 57 years old, male, is very healthy. He expects a long life expectancy. There's definite biomyocardium present in the CTO territory. Technically straightforward total occlusion in a large epicardial RCA. Thus, minimizing adverse effects and maximize efficacy is needed for asymptomatic CTO revascularization. I prepared two discussion points. The first one, plus, now CTO is really flourished. For the recent 15 years, success rate continue to increase up to 80% or 90%, with complication rate less than 0.5%. Why not CTO intervention? Plus, benefits of successful PCI for CTO is shown here. Improvement of ventricular function, improved symptom, improvement in event-free survival is shown on the right panel. When CTO PCI is successful, event rate is dramatically decreased. The final is not well acknowledged. Quality of life is really improved. Cold, clammy extremities get warmer. Sexual function dramatically improved, especially in younger male patients. Plus, the second point is shown here. Even though echocardiograph finding is hopeless, but when we see the MRI, we can see some viable myocardium there. This slide shows the grade of transmurality and in fact determines the recovery of contraction after successful CTO intervention. Red bar end-diastolic wall thickness, baseline. Blue, systolic wall thickening just before CTO intervention. Yellow, 5 months after successful CTO intervention. When the transmurality score is less than 25%, 75% of myocardium is viable, then we can see significant improvement contraction from blue bar to yellow bar. In 50% transmurality score, still significant improvement after successful PCI. Thus, we have to be more cautious before we gave up CTO intervention. Today's angiogram shows here, left, not particular difference with big collaterals from diagonal to PDA plus. You can see plus aleocranial, more definitely epicranial, aleocranial, spider view. We can see the collaterals from diagonal to PDA through corkscrew epicardial collateral channels, plus epicaudal view is very low chance of septal collaterals, plus RCA, no change. We can see the direct connection, plus, but the other angle, such a direct connection disappeared, plus RCA, plus. Okay, this is the done. From now on, I'd like to test the CTO segment with XTA, with very gentle manipulation. I think there's no direct connection here.
Yes.
Okay. I have to be very cautious. A little bit pull back and redirection, and a little bit gentle manipulation of wire.
What is your guiding catheter?
AR1.
AR1. And do you prefer transfemoral approach?
Yes. Plus. No. Testing.
Is this filter XD or XDA?
XDA.
How do you feel? Do you feel strong resistance?
I don't push wire, just rotating, and a little bit bending. The natural kind of extending force may be a driving force, not push the wire. Just a little bit bending. Test it.
Okay.
Test it.
Okay.
Wrong direction. I think there is no direct connection, and I would like to tip shaping more.
Do you use microcatheter, such as the fine cross?
Backup is not an issue for these patients. Direction is very important because the CTO segment does not have any calcium, but various misguiding breaching collaterals. There are two factors in CTO intervention. The first one is right direction, good manipulation of wire to target the true distal lumen. The second is backup. But in this case, backup is no issue. Just manipulation of wire gently is very important. Dye staining,
Yes.
because
subintimal.
of subintimal tracking, a little bit tracking of the XDA wire. This is RO image.
This is some angled distal portion.
Minus?
Yeah.
This
This
is
image is
AP.
not straight.
AP minus. This is LAO.
Yeah.
Cranial. Okay.
Octally angled lesion.
이미지를 보여줘야지. LAO. 오케이. 알아요.
Now you put crochet.
Crusade. I think it is. I'm not sure. First, I try to check. Okay, I see. 알아요 이미지하고. Roadmap image is well matched to the wire direction, but concern is when we perform a dye injection, the dissection may propagate. That's a difficult problem here. There is no
outside.
sense of tactile sense in XDA wire. No resistance, but it may be intima. Okay, AP. AP 로드맵. 한쪽은 로드맵을 넣어주면 그 우리 청중들이 좋을 것 같은데. 좀 어떤 것 같아? In any way, if it is wrong subintima, I'd like to choose the second wire. So I'd like to gently navigate this wire more distally if it is true or not. How do you feel? True or not? True?
Wire
This is
movement.
LAO image. LAO. Cranial. This is LAO cranial image. Remember, and I will play the previous reference angiogram, LAO cranial. Okay, LAO cranial image 보여줄게요. This is LAO cranial image.
If you can select the branch freely,
Okay.
it's true.
Sometimes the subintimal tracking will delineate the side branch also. Thus, of course, there is high probability of true lumen when we go to side branch, but it is not necessarily a authentic evidence. But anyway, I try to navigate several side branches.
Okay.
Okay. Another side branch.
Is there a possibility to use to do contralateral injection from the left coronary artery?
It's a good idea. Then, do we have to puncture the other vessel? How long do we have?
It looks like in the true lumen.
This tournament? Okay.
Yeah.
Just once again, antegrade angio. Advanced guiding catheter. Crusade is weak.
It's very
Okay.
Yeah.
I'd like to change the microcatheter to Corsair. I advanced Corsair. How do you think about microcatheter dye injection? If it is false lumen, it may induce big dissection at distal RCA.
Actually, confirmation not pushing in by angiography must be preferred. However,
But
this
anyway,
situation,
it make kind of. The conclusion is there is no direct connection, and XDA, we just let the wire to find the kind of softer portion to finally end in the true distal lumen. 2-0 track. Deflation.
Dr. Kim?
Okay. Just inflation.
Dr. Kim?
Yeah.
Yes.
So you do
Yeah,
IVUS.
I passed the 2-0 track balloon. This is angio 보여줘야지. angio 2-0 track balloon inflation plus 3-0 track balloon inflation from Abbott Vascular. My favorite balloon catheter because performance is excellent. This is angiogram after repeated sequential consecutive balloon angiography. We can see a big RCA territory. Part of them hibernating, part of them are infarct. Then we perform IVUS. You can see the IVUS starting point. Then IVUS, please.
IVUS, please.
Okay. So we can see a big hematoma by IVUS testing. Then I localized the extent of hematoma inflation. Then I decided stent coverage area maximum. That is distal RCA, just proximal to PDA, plus deflation. Okay, maximum inflation. Deflation. Maximum. Deflation. Maximum. Deflation. Okay. Stand, please. I tried to deploy Zion's Alpine 3 by 33, 38, the longest one, from this RC to mid RC. It's long, but swift. Test 준비. Test. Okay. Deflation. 10. Okay. Deflation.
What size? 3.0.
3038. Inflation once again. 20 minutes. 20 seconds. Deflation. Due to time limitation. Due to time limitation, I shortened the inflation time, usually 20 seconds or more. Here's a 38. Okay, test 준비. Test.
Okay, may I ask you one question?
Okay. The length of the treated segment is long. If we deploy BRS, the longest length is about 28, then it requires about 3 or 4 consecutive implantation. And furthermore, at RCA ostium, the vessel size is about 4. It requires 4-0 stent. Thus, in this case, I really hesitate BRS implantation. Next stent is 3.5 by 23. And my third stent would be 4-0. Nowadays, young in fashion is the one of very interesting feature is they perform stent inflation very short time, just 5 seconds. It's totally wrong. It does not reach nominal diameter. 아무도 안 부르시나? 20 seconds. Deflation. 동준. Once again, inflation. Nominal. Deflation. This is 23. Then we have to check the length of the third stent. Okay, 스네 준비. Shoot. This is a 23 stent balloon and it requires about 28. Okay, 4028. I prefer durable polymer DS because fluorocopolymer coated on the Zions is actually thromboresistant, better than bare metal. Thus nowadays, several OCRO and Synergy emphasize the biodegradable polymer, but I think polymer is not a main issue. degraded polymer DS or durable polymer DS, the performance is determined by stent, strut, or design. Of course, stent strut is a very important factor, and conformability guarantees good apposition. That is also a very important virtue of DS. My point is, polymer is a minor issue, but all the polymers are not the same. We can see that still there is a kind of staining at the CTO segment. Here is a big RCA.
And then there is a small slow
Minus.
probe.
Minus. CTO, I think CTO intervention contains really unexpected happening, and so thus I always prefer the perfect preparation. That's the reason why I just do femoral. If it's necessary, just puncture in contralateral femoral artery, and we can get 8 French if it is necessary. Thus, success of CTO intervention is important. For that purpose, I invest something, femoral artery rather than radial artery. How do you think about slow, mild compromise of PDA?
Post PDA, there is some embolization in this.
No, just stent strut pinched carina shift with contralateral flow, competing flow. Okay. LAO, how many minutes do we have?
7 minutes.
7, okay. Y 한 개 더 줘볼까? 그거나게. If it's a time, I'd like to pass the wire to the PDA and inflation. Not Sion Black. Personally, I prefer prolonged DPT if patients well tolerate. If there is an issue of bleeding easy bruisability, then I maintain the DAPT until just 1 year, because 7 minutes are left. I have to show you anything, something, In terms of DAPT, clopidogrel addition may be helpful to prevent occurrence of de novo plaque in the other segment. Thus, I think if it is well tolerated, I think DAPT would be better than monotherapy. But if easy bruisability is a concern for the patients, then why not? Just clopidogrel monotherapy, not aspirin monotherapy. Because the price of clopidogrel is very cheap in Korea due to launch of generic product, just 1 cup of coffee.
In Seoul, 1 cup of coffee is very expensive.
Expensive? $3, $4?
Yes.
Okay. Just I finished the procedure by kissing ballooning. Okay, I got 2-0. To save the balloon, I'd like to use previous 2-0 balloon to open the PDA and use stent balloon resistance.
Okay, Dr. Kim, please do your job. Thank you for your nice case and nice explanation for all the
Inflation.
procedure. Thank you very much.